Hi, everybody. Thank you for joining us today on this really exciting Q&A session. We have two great speakers tonight, Dr. Uri Soiberman and Dr. Evan Kaufman, who have, graciously read through the answers that you all suggested early on. And of course, I'm your host, Karen Lee. We are here on behalf of the National Keratoconus Foundation. Now, before we get started, I just wanted to do a quick introduction. So Dr. Uri Soiberman, he is an associate professor of ophthalmology at the Wilmer Eye Institute, and he's a cornea specialist, really focusing on keratoconus patients, corneal transplants, cataract surgery, and intraocular lens complications. Before joining Wilmer Eye Institute, he did receive his medical degree from Sackler Faculty of Medicine at Tel Aviv University in Israel, and he completed his ophthalmology residency at Tel Aviv Medical Center. And of course, we have Dr. Kaufman here, his counterpart, our optometrist tonight. He is specializing in medically necessary contact lenses and is an associate professor at the University of Virginia. And there he is active in training residents, fitting specialty contacts, and of course, running a primary care clinic as well too. So just very busy all around. Prior to joining there, he actually went to Indiana University School of Optometry, which is where I went, Hoosiers. Got his optometry degree, and then he did a ocular disease residency at the University of Kentucky. So thank you again, you guys, for joining us tonight. We have so many questions to go through. We're going to start with probably the most popular topic, which tends to be contact lenses for all our keratoconus patients. And we got this really great overarching question that I want us to start with, which is, Dr. Kaufman, what is the current state of the art with respect to contact lenses for keratoconus patients?
Well, thank you, Karen, for that wonderful introduction. I also want to thank the National Keratoconus Foundation for allowing me to talk to all you wonderful people. When it comes to contact lenses, fitting is kind of an art because you have to be able to, or the practitioner has to kind of be able to identify a two-dimensional picture that we might scan and put it together three-dimensionally in order to fit a contact lens on that eye. And I really liked this question about what the state of the art is with contact lenses, because I actually believe that the industry is moving faster than the clinical based practitioner. And right now, if I had to say where is the contact lens going, that we are very interested now in understanding the toricity of the sclera. So, before we had scleral contact lenses, and I kind of mock that because the first contact lens ever invented by man was created by Leonardo da Vinci in 1508, and it was actually a scleral contact lens. It didn't come to really fruition until our manufacturers provided adequate materials that allowed enough oxygen through the cornea. But we spend a lot of time understanding the toricity of the cornea, where in a scleral contact lens, it's not even supposed to touch. And so where the contact lens is landing is on the white part of the eye, or the sclera. And we know that the toricity of the sclera is not the same as the toricity of the cornea. And imaging the white part of the eye in an appropriate manner can be very difficult. And we're just starting that technology to be able to figure out where the steepest parts are and how we can land the contact lens on the white part or the sclera of the eye in order to properly fit the patient. And now we have the technology to do that. And one of the state-of-the-arts lenses is molding a contact to the eye. And I don't own any stock, and they don't allow me to say this, but the eye print is very much like a dental mold, where they take an impression of the teeth. Well, you can put the same mold in the eye and have it solidify in order to get basically like a fingerprint of your eye and properly fit the patient. So that is kind of where the industry is going. We have now, through certain tomographers, which is different than topography, which allow the patient to look slightly off axis, and we can image the white part of the eye digitally, and then we can make a lens digitally, instead of putting a lens on the eye and say, oh, I think I see this and I think I see that. We can actually put numbers associated with it. The industry also has produced higher order aberration lenses, and that's a touchy subject, especially between optometrists and some corneal specialists, because if we are convinced ourselves that we can properly eliminate higher order aberrations, which is in every cone. Keratoconus chronically are something called have high coma, which is a type of higher order aberration. The problem is if the lens doesn't fit the same way every time, and within millimeters or less than within millimeters in the same place, you're not really doing anything to the patient. So it takes a lot of patience, it takes a lot of lenses, and it takes someone that can fit a lens very, very specifically on the eye. But these technologies will continue to grow, and I hope my colleagues in the contact lens fitting world will spread the education of newer technologies in order to put this in the hands of every community that they have. It's not open. I mean, anybody can do these things, but it's far and few between to find optometrists that have those technologies.
Yeah, so what would be your recommendation for a patient to try to find a doctor that has those technologies in their office?
Well, bigger institutions, not necessarily educational, but big practices that are multidisciplined, where they have multiple ophthalmologists, whether it's in cornea, in glaucoma, in retina, neuro-ophthalmology, and that also co-manage with optometry, usually have the means to implement these technologies in their practices. And everybody can guess that with advancements in technology, the price of care goes up. And until you make it standard of care, it's sometimes difficult for local, smaller practices to implement those practices. Schools of optometry want to educate their students on the cutting edge. So you will definitely find these technologies if you have a local college of optometry in your local area. Most departments of ophthalmology in educational institutes like UVA, Duke, Wilmer, they're trying to educate residents and students. And when you have a multidiscipline institution, it usually leans well to have the state-of-the-art technology. And I say that because I think the best care for patients is when ophthalmology and optometry work as a united front. I will tell you, we have 4 corneal specialists at UVA, and I value every one of them, because if I have a problem where I don't know the correct answer, or I feel the cornea is in danger of having a failed graft or an ulcer or something of that nature, I feel that I could go to any of our corneal specialists and co-manage the patient effectively. And if the more united front that we have, the better off
Hmm.
we're going to be. And I think that that not only bards well to the advanced cone, but also the undiagnosed cone and the young emerging cones. Because sometimes I will say in my own profession, we'll say, oh, you don't, you're a young cone, it's early, we don't really need a second opinion. I know what's going on here, and we'll just kind of wait and see. And
Yeah.
that's the wrong attitude. We need to nip keratoconus in the bud the earliest that we can detect it. And I'm certainly not doing corneal cross-linking, but I know my corneal specialists are. And so
Hmm.
we need to, I need to go to my corneal department and say, this, 12-year-old, I think is going to be an emerging cone. We need
Hmm.
to effectively treat it early.
100% agree. Well, also, I'm going to put in a plug for the Scleral Lens Education Society, scleralens.org. We have a Find a Fitter map where these are doctors, optometrists, and whatnot who have proven that they know how to fit a scleral lens and get their fellowship through that society. And once they get that fellowship, we put them on a map, and we actually have fitters on, I think, every single continent now except for Antarctica. And so, always reach out to that organization. They can try to get you in touch with somebody as well. Now,
Even
let's,
some of the manufacturers
yes.
that produce scleral contact lenses can tell you, oh, I really know there's a really great doctor down in Florida that I think will really help you.
Hmm.
And so even though there is quote unquote not a main site, if you can, if you know that your scleral contact lens is made by Bausch and Lomb, I'm sure that there would be a representative at a manufacturer which would say, well, gosh, I know somebody in Indianapolis who would really help you out. And so I think we can also use manufacturer referrals in addition.
That's a great idea. I wish I thought of that myself. Now, let's say the patient's lucky enough to find a fitter and they get that lens fit. It sounds like customization nowadays is the key. We're customizing everything from the haptics down to the optics. What tends to be the limiting factor I find in clinic is the application and removal of the contacts, right? Like your patients always have one eye that's tougher than the other. Let's say they can't open that eyelid enough, it just seems very snug. What would be your remedy for a patient like that to get that lens in?
Well, that's a daily occurrence for me.
Hmm.
Is Some practices will have INR trainings specifically where you can say, I need to sit down with someone that is comfortable dealing with lenses, and it might take me 2 days to figure out how to do it, but I will get there. I will put a plug again. I have no financial disclosures here, but there's a dry eye clinic, and they have multiple devices for insertion and removal. And I find them very useful. There's a hands-free device, particularly for scleral contact lenses.
Hmm.
If you are one of those patients, and I am one of those patients, I cannot put a contact lens in my eye. I can put it in a 4-year-old baby, and I can put it in a 90-year-old adult, but when it comes to me, I don't have the coordination.
Hmm.
Um, we might have to say, well, maybe scleral contact lenses are not what we need to do. I mean, we have been fitting RGPs that go down all the way down to zero point 0.8 millimeters and maybe even more, 5 millimeters. And that's, a very small lens that can be fit, that can give good vision. Now, it's older technology. It's not where the industry is going, but you can have the fanciest, most expensive scleral lens, and if you can't get it in your eye, it's no use to you. Um, Personally, I feel uh, that if I spend enough time with the patient, we can get it in. And
Mm-hmm.
if you can't do it with your hands, if you might have a little bit of Parkinson's and you shake too much, you might is that sometimes you need a device like a hands-free in contact lens inserter. And but there are products out there. There is a Facebook site for scleral contact lenses, and these are people that are on Facebook that are dealing with insertion and removal problems, and they say, "Have you tried this?" One remedy I will tell you is that every scleral contact lens needs to have saline solution put into the lens before you put it in. And sometimes, even if it's room temperature, the minute that touches your cornea, it feels cold and you jerk back. Okay.
Mm-hmm.
When I have a patient that has problems with insertion and removal, I put the saline in my hands and rub back and forth to kind of get it a little bit hot, and then I put it into the disc, and hopefully they don't have that knee jerk reaction to a room temperature saline. Um, I'm trying to think of some other
Yeah.
tricks
You,
that I know of. Um, that getting the lids out of the way is a
mm-hmm.
primary issue. And I have started to use it's a product that costs $5, and you can hold it with one hand and spread your eyelids. It kind of looks like an eyelash curler,
Hmm.
but you can spread the lids. It looks like scissors in combination of an eyelash curler, and you can spread your eyelashes and then insert with the other eye.
Oh.
And I don't like to have too many hands around the eye. Too many cooks in the kitchen
Mm-hmm.
is not a good thing. But if it works for that patient, then it works.
Yeah. You when you talked about that knee-jerk reaction, that kind of jogged my memory. I had this memorable patient at University of Houston where it took three people to get her lenses on. She was an advanced keratoconus patient, and I think as a protective measure, she was really blinky and jumpy. So we had one student behind, like pushing her head down, and we had another student spreading her lids open, and I was like the one putting the lens on there. So sometimes you might have to phone a friend, you never know. And to add to what you mentioned about those hands-free tools, there's the lens base from the lensbase.com, and there's the sea green lens inserter from Dalsy Adaptives. Both of those worked really well for my patients in clinic. I'm not sure, Evan, if those are things you use as well in yours.
Uh, you know, uh, my philosophy is to get the job done. And
Mm-hmm.
as long as it doesn't hurt the patient, if the patient says, I've had a patient that refuses to use a plunger. And I'm like, how in the world can you refuse to use a plunger? But the idea of it made them nervous, and they have learned to put the contact lens in with just their bare fingers. And I said, that's
Mm-hmm.
10 times harder than it should be. But for that
Yeah.
particular patient, it's what they needed to do to get the job done. And as long as
Mm-hmm.
it didn't cause damage to the eye, I'm a happy camper with that. And when I also tell patients who are very frustrated, it's like riding a bike. Everybody falls the first time, you know, and eventually, the more that you do it, the more attempts that you get it, there will be a time that you get it in. You say, oh, wait a minute, I need to tilt my wrist down lower, or I need to push up higher, or it's very difficult. Everybody has difficulty until they get it, and then
Mm-hmm.
it's repetition. It's motor memory for the muscles.
Mm-hmm. So let's say they've done it enough, they've mastered application removal, but for some reason, maybe 6 months or a year down the line, they come back in and they're like, Doc, after I wear my sclerals for about an hour, my eyes start to get red and I start to feel burning. What can I do to make my lenses comfortable again? What would your recommendations be for that patient?
So um, we put all our patients, no matter if they're having redness or they're doing fine, through the same protocol when we see them. And we image the contact using anterior seg OCT technology. And that gives me an idea if the lens is touching at any point. From a practical point, an optometrist should be able to put them in front of their slit lamp and shine a light in the eye and tell if the lens is sitting well or not. But we're talking about micrometers of clearance. And sometimes the lens might be too flat. Sometimes the lens, which might be touching the eye, which could cause redness in an hour. Sometimes if the clearance of the contact lens is too volted, the eye can become hypoxic and not have enough oxygen. The oxygen permeability of scleral contact lens is probably the number one issue that all scleral contact lens providers have to be cautious of. And the reason is that with a small lens, an RGP, a tiny lens, oxygen can go around the contact lens and feed the cornea. But if the lens is adhered or lands on the white part, the amount of oxygen that gets underneath the contact lens around the lens or under the landing zone is minimal at best. So the contact lens depends 100% on oxygen that gets penetrated through the contact lens. But just because it penetrates through the material doesn't mean that it penetrates through the lift or the seg of the seg height of the contact lens. And the farther away that the contact lens sits from the eye, the less oxygen the cornea gets, which then can become inflamed. It can lead to inflammatory mediators and fogging of the lens, where you have histamine and leukotrienes and all the inflammatory agents caught up in the fluid that the patient had initially put into the lens. So understanding the volt of the lens is a critical area, especially if they're getting redness within an hour. Then we come to a whole separate issue of where the contact lens is landing, and are they kinking off blood vessels, which we call blanching, or do we see lift, where the contact lens might be gently touching the white part of the eye and then lifting off, and every time the patient blinks, he feels that edge. And so the original question I think you said is, what would you do if a patient had redness and discomfort within an hour? And to me, that is a most likely misfit lens, and that the patient needs a thorough contact lens evaluation from someone that sees this on a daily basis. Sometimes we have local and optometrists that might not have all the resources that other fitters have, and they say, "Oh yeah, this fit looks pretty good. I'm happy with it." There is no pretty good. There is, it fits right, and the patient's happy, or we need to refit. And so I don't think that there is an immediate cause for redness after an hour. I will tell you that when people come in and say that their vision fogs up, looking through a thick mist, I would say that we call that midday fogging, and I would say most likely the lens is too volted and it needs to be pushed down. The other issue is if the contact lens is leaking fluid from something like a pinguecula, or those little sunspots that we get at 3 and 9. Sometimes the fluid can leak out of that, and we can experience discomfort. But that's nothing that would prevent me from still fitting the patient with a contact lens, is that we can volt over that little pinguecula. We can bring the seg height down. but we have to identify the cause, and that
Yep.
is probably what I would say to the patient.
Yeah, if this was my patient, I would probably want them, like you said, to come in wearing their contacts so that it's at least happening. Because when you go to the doctor and you're like, my knee hurts, but of course, the day I'm in your office, my knee doesn't hurt. It's kind of tough for
Yeah,
them to diagnose. And in addition to you coming in wearing that lens, I would say, let's bring all your solutions, everything you use at home, because it could
yeah,
definitely be. Maybe we misunderstood the filling solution or we got the wrong solution because it was on sale and they all look the same at the store. So many
absolutely.
different moving parts, right? And on
Yeah,
top of what you said, we're also chasing a moving target with the eye. The eye itself is not going to be the same shape all the time. You're going to have allergies, you're going to have pingueculitis and things like that. So I remember I had a patient who had a very similar issue, but it was his rheumatoid arthritis that was acting up, and he started to develop this little like ulcer on the edge of his cornea. And so it really could be anything. Just go and check it out with your doctor, you guys. So now a question for Dr. Soiberman. Let's say we have a really interesting case. We have a 62-year-old patient who was diagnosed at age 44 with keratoconus and appears unchanged for the last 18 years. He's wearing GP lenses. What are his or her chances of their vision never progressing and that their condition just stays like this?
Hi, Karen. So it's nice to hear you two talk about contact lenses. Thank you for doing everything that you're doing. And I just wanted to mention to all of our viewers that really these new contact lenses have been amazing and completely changed the way that we treat keratoconus. Many of the patients, because of you, don't need surgery. So first of all, kudos to you. But
Hmm.
back to your question. So you're describing a 44, I'm sorry, a 62-year-old patient who was diagnosed at 44. So that's
Yep.
pretty far in the game. Usually we make the diagnosis earlier in life. So I can only assume that that patient probably has a relatively mild disease, wearing
Hmm.
gas permeable lenses. At 44, assuming that the disease is not severe, that the cornea is not super thin or super steep, or that the patient doesn't have active eye rubbing, uh, it is very likely to assume that they will remain stable. But there's only one way to know for sure. Bring them back. Bring them back a few months
Hmm.
after the initial exam, see how they're doing, ask them to, if possible, not to wear the contact lenses for a few days before the procedure. We always tell them to not wear the lenses for a couple of weeks, but realistically speaking, patients with keratoconus can't really do that. So I'm usually a little bit more permissive and say, even if it's a few days, it should be fine. But I don't expect patients with keratoconus in their 40s or in their 50s or in their 60s to have to have progressive disease unless something is happening. That's not the rule.
So I think you're totally right with it being mild. This patient says that their other eye actually has never had keratoconus detected in it. So it does sound like quite a mild case here. With the
I would
66-year-old or 62-year-old patient, would you recommend cross-linking at all to kind of keep things stable?
So, cross-linking really has, I mean, it really depends on who you ask. There are many, many approaches to cross-linking. And I should say in advance that my approach is, I guess, a little bit more conservative. I do believe that at least when it comes to surgery, less is more. But when you need to do surgery, you need to go for it. I try to cross-link only patients who have progressive disease unless they're very young. And I make this exception for very young patients because there is data that suggests that younger patients in their teen years can have improved vision after cross-linking. So by doing cross-linking on these patients, you really get two goals. You obtain two goals. One is to prevent additional progression, and the other one is to improve their vision. Unfortunately, that's not usually the case in older patients. They may have some improvement in vision, but it's usually not significant. Judging by the results of the big studies that were done here in the States, it's a line or maybe two lines of vision. In practicality, I don't see it in my cross-linking patients. Most of them just remain stable. So for
Mm,
a patient who's in their 60s and They do not have progressive disease. I personally do not feel that they have much to benefit from cross-linking, but maybe there's something else they could benefit from. Maybe another type of corneal procedure, like maybe CARES. Maybe if they have a very mild cone that can benefit from an approach where we do tipple-guided PRK combined with cross-linking to maybe make them less dependent on contact lenses. And as Evan mentioned, some patients are not always able to put these contact lenses in their eyes, and furthermore, they lose this ability later in life. Like we all lose all sorts of stuff. We're not going to get into that. But these are options. And of course, sometimes these patients just have cataracts, and by doing cataract
Yeah.
surgery, you can really improve their vision in a way that gives them a new view of the world, so to speak.
So
Aaron,
let's
I
talk
would
about
like
the, oh, go ahead, Evan. Yes, yes.
I would like to, from my perspective and my what I would say definition of keratoconus, it's bilateral.
Hmm.
And uh, although I don't know the specifics of the genetics, there has been research that it is a genetic condition that we have. So part of the issue that I have with the question is that I do not, no keratoconus was discovered in that eye. I think that in this particular patient, that she might have keratoconus in this patient. It just hasn't flared up enough in order to need to be treated, which is a very good scenario because yes, this could be a very mild case. They have a term called form thrust keratoconus. It doesn't even have a CPT or ICD-9 code. We can't, but it just says that it's keratoconus. It's more in one eye than the other, and basically subclinical in one eye. But I would definitely say to this patient a couple things. One is that I believe that she probably has keratoconus in both eyes genetically, and we're playing the odds that it doesn't progress.
Hmm.
When I was in school, everybody said, keratoconus is a young man's or young patient's diagnosis, and I disagree with that too, because we're having more and more people coming in and finding new diagnoses of keratoconus, even in patients that are 40, like this patient was. Now, the fact that she hasn't had any progression in 18 years, I think is great, but I would also like to see her tomography or topography or whatever was available at age 44, and then I would like to see it at 62 to see. Well, she might not have experienced changes in her vision, but she could have had progression in the keratoconus. So maybe her cataracts grew at the same rate that her keratoconus grew, and she had been told that, well, the vision deprivation that you might be experiencing is not the cone; it could be the cataract, which I think is a really clever thing that Uri just said, that there could be other things, could be macular degeneration or something that could be
Hmm.
leading to her vision uh, deprivation. But I might be a little bit on the opposite side from Uri in the fact that I don't. I would refer for a corneal specialist's opinion, regardless if the patient is 62 or if they're 44, because since I'm not behind the machine, I wouldn't want to be responsible for any progression that might occur even at 62, which
Hmm.
is probably unlikely and is probably, but I would want to co-manage this patient closely. And probably one of the greatest things I heard is that we would maybe see them every 6 months and repeat corneal tomography and see if the numbers are progressing. even though the patient might not be aware of that.
Definitely keeping a watchful eye over your patients is important.
Yeah,
Now,
Yeah,
let's
point
say,
taken. Send them over to me, Evan.
you got it.
so Uri, with your conservative approach, would you ever cross-link an eye that already had high drops?
Again, that depends on the eye. These hydrops eyes usually have such severe disease that, first of all, they thin out. And one of the problems that we have with cross-linking is that we can't really cross-link in a safe manner eyes that have very low corneal thickness. The procedure could simply damage the cells that live in the back of the cornea, the endothelial cells, and that's something that we do not want to get. But the other issue with high drops is that high drops leads to corneal flattening usually.
Mm,
And what Evan implied is that in order to identify progression, we're looking at tomography, we're essentially looking at the shape of the cornea, and we're trying to understand from these scans whether the cornea is becoming steeper. In patients with high drops, usually what you see is that as they heal from the high drops, the cornea flattens. So there is some dynamics in the shape of the cornea around eye drops. I think that before cross-linking a patient with high drops, you really want to make sure that they have progressive disease and better understand what we're trying to gain by doing the cross-linking. In many of the
mm,
patients who have high drops, they have poor vision because they have scarred corneas. Uh,
mhm,
Cross-linking is not going to help that. These are the kind of patients that if you can't help them with a specialty contact lens, they will probably need some sort of surgery, whether it would be a pre-descemetic DULC for patients who still have relatively clear corneas, or a full thickness corneal transplant. My suggestion in the setting of high drops is, of course, to see a cornea specialist and to address this matter very carefully before making any decisions on cross-linking. I think that it's important to have a good heart-to-heart conversation with the patient. That's always true, and see what their goals are, and to really be very honest about what we can give them with
mhm,
cross-linking. Cross-linking is not for everything. Not everything that says keratoconus on it equals cross-linking.
mhm,
But yes, Evan, I agree with you also that it is almost always a bilateral disease, but it can be highly asymmetrical. You know, there are studies that show that it's worse on the eye that the patient sleeps on. That's not always true, but I
mm,
always ask. As for genetic disease, I don't know if keratoconus is genetic. It's genetic in a small proportion of the cases, but it's definitely
mhm,
bilateral.
mhm.
The
So let,
this is an interesting question because it ties into one of the questions that later come up about
mhm,
the structural formation of keratoconus and why cross-linking works. And I tell my patients that I want them to imagine a 90-year-old adult who has been sunbathing in Miami for their entire life. Their skin is skin touch, or there is sun touched. It's leathery. It's tough. And
There are
in that
lenses too.
scenario, say that again.
There are lenses as well.
Oh, their lenses as well. And so they cross-linking is kind of, and I hate to overstep my bound here, but giving the eye a sunburn, because when we remove the epithelium and we expose the eye to high energy uh, ultraviolet radiation, they strengthen the lamellar bonds between the cells to make the lens less flexible, less soft, and more stiff. And so basically we're going from, my example of a smooth baby's bottom to a 90-year-old sun-kissed leathery skin. And when we have high drops, is that there's a break in one of the layers of the cornea, and the cornea swells from edema, but then once the high drop episode is over and the lens becomes more flat, I feel that the bonds in the stroma have actually strengthened. I actually think it's the body's way of almost cross-linking the eye already. And so I'm kind of on Uri's track here, which I would proceed with caution with people that have had high drops, because I'm not sure it's a great benefit. And that's from an optometric standpoint, not a
Hmm.
official contact corneal specialist's opinion.
Well, nothing here is official because none of us saw this patient, but having said
Hmm.
that, yes, I agree with you. It's a scarring. Do we have any other questions from our viewers?
Yeah, so let's say you do cross-link a patient. How long do they have to stay out of their contacts prior to the surgery? And how long after cross-linking can they finally wear their contacts again?
So I usually like to have updated pentacams for the day of the procedure, unless I got the pentacam maybe say a month before. But if it's 3 months before, sometimes people really have to wait for a long time before they get the cross-linking. So I want to get a very good, accurate reading from the pentacam so that I would know what my baseline is. So in order to have a good baseline, they need to be out of their contacts because we know that contact lenses can change the shape of the cornea. And then I would never know whether that change in the shape of the cornea was because of keratoconus or just warpage effect from their contact lenses. So anyone who wears contacts, I do ask them to take them off as well, again, being realistic about it, if possible,
Hmm.
at least a week.
Hmm.
As for how long they should be out of their contact lenses, there's really very poor data to suggest that they can't wear their contacts starting early on. I guess that what I usually tell them, and it's not based on any evidence, is that if possible, I would prefer that they would wait for 3 months. I'm always concerned that wearing contact lenses during that time when the cornea is remodeling can change something in the shape of the epithelium, not so much in the shape of the stroma. And I'm always concerned about infections because it's a kind of a
Hmm.
critical time point or on the steroid drop for about a month. But the patients who are really contact lens dependent, say the ones who have very thin corneas, and we do, say, an off-label treatment like the sub 400 protocol, that I know that they are not going to be able to be functional without wearing
Hmm.
contact lenses. I usually tell them to wait a month. And this is one of the reasons where I try to stagger the treatments. Again, I don't do cross-linking for both eyes in all patients. I've actually published on that and showed that definitely not all patients need bilateral treatment. They don't all progress. Usually they progress in the worst eye. The other eye can be quite stable in many of the cases. But if I do end up performing bilateral treatments, I try to do them a few months apart, at least a few weeks apart, so that they can go back to wearing their contact lenses in one eye before we do the procedure in the other eye.
I could
So,
not agree with Uri more.
Mhm.
Optimally 3 months, uh, but that sometimes people are dependent on their vision, and
Hmm.
they just, particularly keratoconics, and they can't be out of their lenses. Um,
Hmm.
I actually have not seen a bilateral cross-linking done. I have seen a lot of, we refer and get one done and get that eye better, get the epithelium healed, and then do the other eye. Now, I don't know if that's going to be standard of practice going into the future, but it at least gives the patient one eye to, if they need to go to work or something of that nature. I think most definitely they should be out of the contact lenses maybe a week prior to the surgery. If when I talk to patients about the post, I probably say 2 months. But if we get 3 months of out of the lenses, I feel that structurally the epithelium will be strong enough and not cause any later on consequences. And
Hmm.
so I couldn't agree with Uri more on that.
Do you guys find that after the procedure, we've waited the 3 months, they put their lenses on, do your patients need an updated contact lens prescription or can they continue wearing their current lens?
I'll let Evan answer that. What I can tell you is what I definitely see is that after 3 months, most of the flattening effect from cross-linking is seen. Whether that translates to a change in the contact lens, I can only assume yes, but Evan would know more.
So personally, in my practice, I would say that sometimes I see maybe a 2 diopter regression in astigmatism. That being said, any astigmatism is still going to be irregular. And when the flattening occurs, that's going to change the dynamic of the lens and has, uh, as I said before, might the old lens might be too steep, might cause corneal edema and cause more discomfort. So I tell my patients that, there is a greater chance that we will have to fit you with a new lens than be able to use your old lens. But that can also vary on the severity of the keratoconus. So if we're doing cross-linking on someone who's an emerging cone, where the flattening might be more minimal than someone who has a large nipple cone and the flattening is greater, there is a greater chance that we would have to refit the more severe case. But there are no definites, and I never say always, and I never say never. Just that most likely, and I would say most likely there will be a refitting afterwards.
Gotcha.
And sometimes the treatment might be so effective that we don't need to use a scleral. There are specialty lenses such as the Novacone, which is used in early keratoconus, which is a soft lens designed for keratoconic patients who are emerging cones, and we might be able with cross-linking to take those patients out of severity and into a more mild, manageable management of their cone. And they might not have to deal with a hard lens. They might be able to deal with a specialty soft lens or a
Hmm.
hybrid lens where only part of the lens is hard and the soft and the peripheral part of the lens is small. And so I think that uh, only good things can come after the cross-linking has been done from a
Hmm.
contact lens point of view.
What exactly? So let's say, maybe it's truly not the contact lens. If it's a few years out from cross-linking now, and the patient has noticed that their vision continues to deteriorate and maybe their cornea has steepened a little. At what point should their disease stop progressing? And is there anything that patient can do to prevent further deterioration if they've already had cross-linking done?
Yeah, so I mean, the first thing, rule of thumb, is don't rub your eyes. It's something that I tell my patients many times every time I see them in clinic. You rub your eyes, there is a good chance that the disease will continue to progress. There is a myriad of off-label treatment that people suggest. I wouldn't go for any of them, by the way, but I would treat, well, first of all, I would treat comorbidities. If a patient has a lot of allergies and the eyes itch, and as a result of that, they need to rub their eyes, then I would treat the atopic disease, the allergies. There's over-the-counter Pataday, artificial tears do a pretty good job, and so do cold compresses. And if that doesn't work, then I would say see an eye doctor and see if there's anything that we can do to make things better. The
Even
next,
treating their allergies, orally with, Claritin and things of that can help. I think Yuri hit it on the head is that we need to prevent eye rubbing. But I don't think, as I said, there's not always progression, but there's not always stability.
Hmm.
And so, if the, contact lenses will help the vision, and that might solve the visual problem, but that might not still prevent the cornea from becoming more ectotic. And so treating the underlying cause is is without a doubt the go-to post treatment for corneal cross-linking. And you really sometimes need to get into their lives. You need to say, well, tell me, are you, do you suffer from allergies? Have you had trauma to the eye? Have you, what makes you think that we are progressing? And retesting from what Uri said before is that if we have what the steepness and the corneal findings prior to cross-linking, and then a year later we see that the numbers are changing, well, that's more proof that maybe the keratoconus hasn't quote unquote flamed out, and maybe the rigidity of the cornea secondary to the cross-linking wasn't enough. But I would yield by far to a specialist like Uri that I would say, do you cross-link the patient? And I don't have necessarily an answer for that.
I've done it on a handful of patients. Sometimes you have to
Mhm.
repeat cross-linking, and sometimes it works and sometimes it doesn't. And if it doesn't, either way, that sounds to me like a scenario where a patient really needs to be examined to make sure that see what's going on. Is it really the change in the shape of the cornea? Is it something else that's going on? Remember, the cornea is just a part of the eye. There are other
Mhm.
elements that can have diseases in them, and especially in someone who's in their 60s, I would want to double check, take a good look at the lens, make sure that there are no cataractus changes, of course, the macula, the optic nerve. But I think that there were a few questions about corneal transplants. Maybe we should touch on
Yeah.
that. I see that we only have a few minutes left.
Yeah, so that's definitely our next area. I was going to ask you guys, cross-linking, maybe that didn't work. We're heading into the transplant territory. What's the current state of the art or recent advances when it comes to cornea transplants? And more specifically, can we touch on KeraClear and corneal tissue addition for keratoplasty or corneal allogenic intrastromal ring segments? All three of those, Uri.
Yeah, so it's a lot. So I think that first of all, this is if you have keratoconus, it's a better time to have this disease than say 20 or 30 years ago. There's just a lot more options than there were in the past. I think that in the past, anyone who didn't do well with contact lenses ended up and the contact lenses that we had were mostly those small RGPs. Ended up getting a PK, a full thickness corneal transplant, whereas this is definitely not the standard of treatment that we have today, at least in the large academic centers. Both me and my former division chief, who's now Evan's boss, Dr. Jan, did quite a bunch of deep anterior lamellar keratoplasties at Wilmer Eye Institute, and the results are very good. But if a patient says that they don't want to have a corneal transplant, whether it's a DULC, a deep anterior lamellar keratoplasty, or a full thickness keratoplasty, a PK, there are other options that are minimally invasive. And you mentioned some of them. So one of them is CARES, and the other one, or its derivative, CTEC, which are now both available to patients in the United States. There are other procedures that are minimally invasive that are probably going to be a part of our toolbox in the next few months slash years. For instance, a Bowman layer transplant that may play some role in patients who have very advanced disease. There are the laser procedures, and for instance, topo-guided lasers combined with cross-linking. And finally, we have the last line of defense, which is also the first contact lenses. But when I see patients who have severe disease and they don't have good vision with contact lenses, or they are simply contact lens intolerant, what I usually offer them is DULC. It's bigger procedure, takes more time to perform, but the results are wonderful, and there is data that suggests that DULC may be better for patients with keratoconus than full thickness grafts, especially when done in patients who are very young and who will live with these grafts for many, many years. Patients who have DULC grafts tend to develop less ocular hypertension or high pressure inside the eye that could cause glaucoma, another type of disease that can affect vision. And overall, they maintain more of the cells that live in the back of the cornea, those endothelial cells that act as small little pumps that maintain the clarity of the cornea. You were asking me about KeraClear, which is a type of a medical device that is not FDA approved, but is being studied at a few medical centers here in the US. And if patients are interested, I'm sure that they can find more details about it if they just Google that name. So KeraClear is not tissue. It's not a corneal transplant made of human tissue. It's a type of a device, just like any other device that you implant in the cornea. There are advantages and disadvantages, but the KeraClear is supposed to have some advantages over other types of keratoprosthesis. And I don't have any experience with KeraClear, though. In general, patients with advanced keratoconus do very, very well with corneal transplants from human cadaveric tissue. And unless they are at particularly high risk of graft rejection for one reason or the other, it is unlikely that a keratoconus patient will need to have one of these devices implanted in their eyes. Having said that, some keratoconus patients do have severe dry eye or severe atopic disease, any type of severe ocular surface disease that can make them poor candidates for regular type of corneal transplant.
So we kind of
Karen,
talked about. Oh,
I
yeah,
think
go
you
ahead,
could agree
Evan.
with me that full thickness corneal transplant, as Uri said, is works very well for keratoconus. It eliminates the disease essentially because the donor tissue shouldn't have keratoconus. But what it does is it makes the corneal surface highly irregular because you have the host tissue, which is at one steepness or one K value, and then a very flat surface where the graft comes in. And all of my graft patients make me a little nervous with contact lenses because the shape of the eye can be irregular enough that it's sometimes hard to prevent touch or an ulcer type uh, uh, in the cornea, and no one wants to deal with an ulcer in a graft because you can cause it to fail. It's funny, I guess we might say that our corneal graft patients is the patient that never leaves. They're kind of an inherited patient because they always need constant monitoring of the contact lenses, and they're kind of a more difficult contact lens to fit. And we have the resources and we have the designs, which is usually a reverse geometry central design, but still it adds that second layer of difficulty with it. So,
Mm-hmm.
you know, corneal grafts keep me in business, but I would rather have them had cross-linking before and not get to that severity in the keratoconic state. Now,
Evan, I
the
just want to make a comment that because
yeah,
we're just about to finish, the cross-linking is great, but it's definitely not a treatment for non-progressive yet very severe disease. And if these patients cannot do well with contact lenses, there's really no other good option for them except for corneal procedures. Let's call it that way. It could be CARES, it could be
Mm-hmm.
CPAC, it could be a corneal transplant. I disagree with you, though. The corneal transplants, if done properly, are beautiful. They do cause some degree of astigmatism, that is correct. And sometimes, if we remove the sutures and still there's a significant amount of astigmatism, then these patients will need to wear contact lenses. And I would guesstimate that that would be 30 to 50% of the patients, but they usually have better vision. I haven't seen many patients with corneal grafts that were not happier after the procedure than before, and I choose them very carefully. Definitely not something that I offer to every patient who walks through the door. So let's keep it open. At least tell patients that they will do well if they need to have a corneal transplant. But there is no doubt that we don't want to offer this to everyone. We want to keep this as
Mm-hmm.
a treatment option only for patients who have very severe disease. And yes, it's always best to detect these patients early and to treat them with cross-linking if they have progressive disease. And this is our goal. This is why we're doing these webinars, so that everyone would know that we have these options and they would reach out to us as a group and
Hmm.
have some sort of diagnosis, treatment, etc.
And this
I,
is
I mean,
why we need co-management. This is why I need Uri in my practice so
mhm.
he can
Yes,
give
much
me
more
this
for us.
expert advice on what the proper surgical treatment for the patient is.
Couldn't agree more, you guys. I don't think there's a better patient group out there that could benefit from both optometry and ophthalmology. Thank you both again for tonight. We got through about 80% of the questions. Maybe there will be a part two. Who knows? For now, I'm your host, Karen Lee. We actually don't have a scheduled NKCF webinar coming up, but be on the lookout. I'm sure Mary will be sending you guys emails and whatnot, and we'll have an exciting lineup for you coming soon. Thanks again, you
Thank
guys.
you,
Have a good
Karen.
Thank you very
night. Thank
much.
you.
Bye, everyone.
Bye. Thank you.